Welcome to our webinar. I'm Monika Milewska and I'm representing today Matt from Cryoflex. And I'm really honored to have our guest today, who is Matías Nicolás. He's a board-certified thoracic surgeon working in Buenos Aires in Argentina with over 15 years of experience in minimally invasive chest surgery. One thing in terms of the organization of the webinar, I would like to ask you to write the questions in the chat during the webinar, and please make sure that every single question is finished with the question mark, because otherwise it will not appear on our screen afterwards, as Dr. Matías Nicolás will be answering the questions after his presentation. Of course, the webinar is being recorded, and afterwards everyone will receive the message with the link to the recorded webinar together with the certification. So if you have any questions, please write them, put them in the chat, and we will try to answer them after the webinar. So Matías, the stage is yours. Thank you so much for joining us.
Thanks so much, Monika. Thank you so much. Well, good morning. Good afternoon and good evening, everyone. Thank you for joining us today. My name is Matías Nicolás. I'm a thoracic surgeon specializing in minimally invasive surgery in Hospital Privado de Comunidad in Mar del Plata, which is in Buenos Aires. Buenos Aires is in the coast of Argentina. Here you can see it's a small city, and well, it's a 700,000 population located in 400 km from Capital Federal. I work in Hospital Privado Mar del Plata. It's a high complexity tertiary center, and well, we perform there nearly 450 procedures, thoracic surgeries, including 150 pulmonary resections a year. It's not so big, but we have robotic platforms and a Pectus program where for adults and children. We also work as part of a team in Clínica Pectus in Capital Federal, which is our substantial part of our Pectus Cryoanalgesia data comes from. So we'll talk about our problem, which is why we're here now. It's the pain of the patients, because it really matters. We'll start with clinical problem with post-operative thoracic pain, and then we'll go into the pathophysiology, especially the pain stress. We'll cover the mechanism and technique of cryoanalgesia, moving to the experience across the different settings in Pectus repair, rib fractures, and pulmonary resections, and also the conclusions and their future directions. So, despite all the advances in minimally invasive surgery, post-operative pain still remains a problem for us. There are publications that said that 59% of VATS patients have severe and moderate pain the first 3 post-operative days. So that's a striking number. For decades, the thoracic epidural was considered the gold standard, but it comes with real limitations with hypertension, catheter failure, restricted mobility, and the need for urinary catheter. So it's not always a good election, not for me, because if I couldn't move the patients, you're not doing as an HERAS protocol or a good protocol for patients to quick moving. And also systemic opioids, they're the traditional option, but for me, they are a lot of risk, and like nausea, ileus, respiratory depression, and now the most important, dependency. So that's if we don't treat correctly the pain, the cascade that follows poorly controlled pain, it's no for everyone. Hypoventilation, atelectasis, then pneumonia, and that remains the leading cause of postoperative mortality in thoracic surgery. That nobody wants that. So, and that's also it. When you have patients with the pneumonia, that's prolong the internation of the hospital. So that's enhance the cost of the surgery, and it's not good. So we need a different paradigm. So that's exactly what cryoanalgesia offers now, because it's an alternative to make better things for our patients. So let's talk about the mechanism and the technique of cryoanalgesia. So how cryoanalgesia actually work? The machine exploits the Joule-Thomson effect. Pressurized CO2 expands rapidly through a microvalve at the probe tip, generating a local temperature in -60, since -60 to 75 degrees Celsius. This creates what we call the pericostal ice ball around the target nerve. The tissue effect is selective. The tissue, what happens is a neuropraxia. The axon and the myelin sheath are disrupted, but the endoneuron and the perineuron was preserved, so the structure of the nerve is still working and will remain and will heal with the time. So that means that the nerve regenerates completely over 3 or 6 months. No permanent and histological damage have been demonstrated in long-term studies, so that's the main thing. The key clinical advantage is that it's a single intraoperative application with weeks along analgesic effect. Not postoperative management has required, just patient receive medications for prevent neuropathic pain, but just not opioids, and the patient's really good things. So compared to the epidural, cryo lasts 4 and 8 to 8 weeks with analgesia versus 48 or 72 hours of epidural catheter. So with no hypotension, no full free mobility, and opioid reduction consumption. So I believe it's a good thing, and this is the paradigm shift. Here's some comparisons regarding the cryo and epidural. So we have two approaches. There are two ways to apply the cryoanalgesia. One from inside, that is the thoracoscopic approach, and using direct visualization by VATS or robotic surgery. And from the outside, percutaneously using ultrasound guidance approach, the intercostal, and you find the intercostal bundle by echography, and you put a probe, which is a percutaneous probe. Each approach, as they have indications for each one. You can use it both in every patient, but we prefer thoracoscopic for elective surgeries by VATS, for example, Pectus repair or lung resections. And percutaneous is ideal for trauma patients with rib fractures, for example, or chronic pain, where patients we are not going to operate and you are going to open the chest. So you can do it from outside, guided with ultrasound. So this is the thoracoscopic probe. It's the CryoFlex Cryo-S thoracoscopic probe. It has a length of 425 millimeters with 3 millimeters tip of diameter. And that's specifically for cryoanalgesia of the intercostal nerve in thoracotomies or on bats or rats. And it's designed specifically to apply with that special tip in the intercostal bundle. So now we will see some videos about how you can use it. This is the probe. Here you have two examples in robotic and in Pectus repair. In the robotic, we start from the anterior trocar, and we put in the middle of the intercostal bundle and press to the intercostal, and so that's how you are doing correctly. If you put too high, you are in the costal, and if you go below, also you are in the ribs. So that's not so good, and you have to apply parallel to the intercostal space, not in that way. So there are specific recommendations to do a correct application of the cryoanalgesia, because when you fail in applying the cryoanalgesia is where you have problems with neuropathic pain because you don't do the completely axonal message of the nerve. So you have to push. With all the procedures have to do it with bronchial intubation, selective bronchial intubation. You get into the chest, 1 centimeter medial anterior axillary line, and then for the fourth intercostal space, you get it to all the spaces from the third to the seventh space now, and then you apply the Cryoneurolysis. In this publication from Tuselli in 2024, they perform just for 2 minutes. Now, actually, we are applying for Pectus and for Thoracoscopic procedures the same way, but just 1 minute, and we have excellent results and no changes in the pain management and complications. This is why we go as posterior as we can, because we have found the collateral bundles of the nerve, and you have to control them. This is a paper that found out that nerve, and they publish about what they problem, why have they problem achieving the good cryonalgesia. So they're not going so as posterior as they can. So they found that they have to go 3 centimeters from the sympathetic chain. So there you can find the collateral nerves, and it's how you avoid this anastomosis, because and you don't have to problems about not ablated nerves. So this is a percutaneous probe. We are pioneers in this. We published the way to do how to do it in 2022. We published this short communication and of the technique. You can find it's open access. And this is the probe. That is, you have 2 different lungs, 120 millimeters and 80 millimeters probe, and its diameter is 1.3 millimeters, and it's the way how you use it is using an ultrasound and an angiocat. With an angiocat, and you see directly the bundle. We prefer the oblique view of ultrasound, so you put parallel to the ribs, so you can find easily the pleura. You have to find the costals, and then if you want to see the nerves and you want to see the vessels, it depends on your ultrasound and your technique and how you are manage the ultrasound. But it's not difficult to find how to do it. This is a video for, it's not working, sorry. So there's you find the intercostal space. Now you're doing the punction. So identifying with a high frequency probe placed in intercostal neurovascular bundle, you puncture with an angiocat, 14 gauge. Then you get infiltration with bupivacaine or ropivacaine, what you want, just for atrial dissection, and also you perform a block of a nerve. That what you see is a twinkling to find the probe, and then that what you see is the ice ball, because that's when you are freezing the tip of the probe, make the ice ball, and you can find, and if you are doing, this is how you see when you finish the procedure. It's to confirm that you're in the middle of the intercostal space is where the neurovascular bundles goes mostly, so you ensure you're doing the perfect block. So let's share something of our clinical experience. This is lessons learned from 176 patients, those also from Tuselli, and here is a publication from 1924. It's the recent publication. Here is our objective. like what do you want to do? You have the heart of a patient compressed, and you want to decompress that heart, put that bars, and not have pains. You want the patients that they could have a good recovery, no pain. Well, in this presentation, they have 176 patients. Most of them are children, but they have 41 adults with a mean age of 16 years old, 62 historical with epidural compared. And well, they applied cryonalgesia for 2 minutes. That's a previous protocol. Now we're doing in just 1 minute. And this, how you see, is how the postoperative assess of a pain of patients. They are lower at the second day. Just it's the same first day, and the second day just decrease until the 14th day. It's just 2. They can do exercise. They can move. They are doing exercise very early when they start their recovery with physiotherapists, and that's the main thing because you have to move quickly. And with an epidural, it's not possible to do at the second day or third day. So that's a good thing with cryonalgesia, what they achieve. Here, it's the length of stay compared with the epidural. It's really a reduction of length of stay, 61%, and the consumption of opioids, it's significant compared with the epidural. And also with the oral morphine equivalents, they are really impressive, the reduction of consumption compared with the patients per day and also per kilos, and the total consumption of both groups. So 10 plus reduces of opioid consumption, and the patients, 43% of the patients, 77 patients, they don't receive opiates during the stay. So that's, for me, when I realized that, it's crazy. So I know that this is incredible. Here they compare adults with children. They have 41 adults and 135 children. They don't find any difference, just slightly difference in the number of implants, but because of the sample is too small with adults, we don't have difference in this. So you can treat adults and children with cryonalgesia as the same, with the same results. So that's very interesting for us, because it is not common all over the world that you can operate patients, adult patients, with good results. For me, I establish like a protocol. I don't operate adults without cryonalgesia. Maybe children's, maybe that's not as painful as in adults, but if you can offer same results as children now, I think it's really a shift of a paradigm. Here you can see all patients at the first day of their recovery doing exercise, moving with faces, smiling, and that's why we do this. This is the hospital discharge as first day. Most of patients go with a mean of 1.4. So that's really significant compared with the epidural. So this is the protocol for preoperative, and we may pre-medicate the patients 1 week, starting with pregabalin, day 1 to 3 with 50 milligrams, and then 75 milligrams every 8 hours. First before 1 week before, and then they continue during the surgery and the outpatient at the discharge. We manage the pain with acetaminophen, diclofenac, intravenous, 50 milligrams every 8 hours, pregabalin, and rescues with tramadol if the patients need, and that's why they publish with equivalents of morphine, oral equivalents of morphine. And at the outpatients, the patients receive acetaminophen, ibuprofen, or omeprazole for gastric protection, and rescues with diclofenac and pregabalin. Most of our patients don't consume opioids at the discharge, but if they need it, we give it, but it's not usually. The paper published, it's just 46% of the patients don't receive any opioid, so that's a good thing. So for take-home messages in Pectus repair, the complete line collapse is mandatory for reach the posterior bundle, and the cryo before the sternal elevation, that's mandatory because you don't generate any pain before you freeze the nerve, so it's a good thing. You have to enter in the medial anterior axillary line, so because if not, you couldn't reach all the spaces from the fourth space, and the angle of the tip, you cannot achieve the completely pressure of a nerve, the bundle. So the probe, you have to position the probe in the middle of intercostal space, never in the rib surface, because if you don't reach the nerve. It sounds like something that it's easy, but you have to do it, because if not, we believe it's one of the problems that some groups find, because they found that they have neuropathic pain, and I will believe that is because they're not positioning in a good in the middle of an intercostal space, and they don't produce the correct damage of the nerve. They don't have the axonomesis of the nerve. So this is the more recent institutional experience with Clínica de Pectus and Hospital Privado Comunidad, and with that change that I mentioned about the reduction of 1 minute to freeze, and that we have a significant reduction of cryo application time, and with no difference in the mainstay of the patients. So now it's our new protocol is 1 minute, and with excellent results.
Hello, Franco. How are you?
I'm fine. Great.
How old are you?
28.
28 years.
Yeah.
Okay. And yesterday was your surgery?
Yeah, right. At noon, I have a Pectus Excavatum surgery.
Perfect. With Cryoneurolysis?
Yeah.
And how much pain do you have from 0 to 10?
Right now, 0, really. I have
0.
a bit of pressure in my chest, but no pain.
Perfect. Can I see you do an exercise?
Yeah, sure.
Excellent. Excellent. When are you going home?
I hope now.
Right now?
Yeah.
Okay. See ya.
Bye.
Okay, well, that you can see a common patient that we have, adult patient, and also with kids, and you can see that face happy, and they can do exercise. So that's really, for me, it's a gold standard of cryonalgesia for patients. So let's continue with the clinical experience in rib fractures. That's our last publication. It's published this year in the Journal of Surgical Research, and we publish our series compared with a group with no cryo. It's a retrospective analysis, and we have good results. We operate patients with 2 or more rib fractures, and we perform cryonalgesia. We compare with a control group, a retrospective control, and we use those with osteosynthesis and the follow-up of the patients. We perform the percutaneous because it's better for this kind of patients. You have hematoma sometimes, and patients are not easy to, you cannot access with thoracoscopic probes. So now is where the percutaneous ultrasound-guided cryonalgesia is perfect. These are how our patients look, and we perform small incisions to repair the ribs and spread the muscles. So that things reduce the pain. So you're stabilizing small incisions and also with cryonalgesia. So you're adding each one for better recovery and better pain. So we have 50% reduction in opioid consumption comparing both groups, with 67 patients with less pain at the post-operative. So we reduce the milliequivalents of morphine equivalent dose in those patients compared at the first day post-operative, and at the ambulatory, no patients are consuming at day 30. They are not consuming opioids. So that's really interesting, and for patients also, because they don't have the secondary effects. You can see here how the decrease of a visual analog scale of pain, and how patients with no cryo, they still have receiving opioids at day 30, and also they complain of pain with moderate pain, and they are with less reduction of mobility. So that's a really good result for cryo patients. At day 14, they don't receive more opioids. So this is our multi-modal analgesia regimen, standardized for risk factors. It's quite similar to patients with Pectus Excavatum. We cannot pre-medicate them, but if we receive in the emergency room, we start with pregabalin at the day, and we prefer to operate them as soon as we can. Sometimes we have problems with the social insurance, but we try to do it in the first, 24, 48 hours for better results. So we started with pregabalin, diclofenac, acetaminophen, and rescues with morphine. If patients complain of VATS more than 7, we put fentanyl bolus or pump of fentanyl. Well, it depends. Sometimes we use also epidural, but for the preoperative. Well, the patients get during the surgery, we perform cryoablation, and we manage the pain with oral analgesics and rescues with morphine. So, and at the outpatients, the patients manage with patient with cryo. No, they manage the pain with acetaminophen, etoricoxib, and pregabalin. We use etoricoxib because you use once a day, and it's practical for patients, and they receive just acetaminophen every 8 hours.
Sábado tipo 13:30, ingresé al hospital tipo 14 y me operaron el miércoles 4 de la tarde. Cuando entré era como que me aplastaba todo lo intercostal. No, era un dolor, 9 puntos, era un dolor porque no me podía mover nada. Y hoy la verdad que...
Hoy estamos día viernes, o sea, menos de 48 horas de la cirugía. ¿Y el dolor, del 1 al 10?
No, un 2, un 3, no es eso.
¿Recibiste algún rescate de morfina?
Pequeños, uno solo creo. El primer día que salí de quirófano a la noche, pues...
Bueno,
a 2000 llego.
And this is the experience in VATS and RATS lung resections. This is not published yet because we are trying to reach more patients, but we take a piece of patients from 2 years, and we assess them from lung resections for oncological lung resection. We have patients, elderly patients, because we have our population of lung cancer, it's nearly that age, and performed by UVATS. We ablate, realize 3 levels, and because of UVATS, so we perform the incision of 5th space, and we treat upper and below intercostal space. And well, the chest tube duration is 26 hours. The length of stay, the mean is 2.1, and the in hospital oral morphine equivalents require at 3.3, and at the outpatient receiving opioids, the most of patients receive opioids just the first day, because cryo start working at 24 hours maybe. So that's why we use morphine at the first day. But at the outpatient, just 4% of our patients receiving opioids. So that's incredible for lung resections. And here, I hope you can hear the sound. This is a patient operated the first day of a tumor of the right upper lobe with neoadjuvant immunotherapy. We perform a lobectomy by VATS, and we perform endoscopic cryo.
¿A qué hora?
A las mañanas, 7, 8 de la mañana.
Bueno, bien. ¿Tenés tubos? ¿Drenaje? ¿Algo?
No, no tengo nada.
¿Tomaste algún analgésico hoy?
Sí, no recuerdo qué, pero tomé analgésico. Pero
¿Una pastilla?
no tengo dolor, sí.
¿Qué era? ¿Paracetamol o algo de eso?
Paracetamol, pregabalina y no me acuerdo qué más.
Bueno. ¿Morfina?
Anoche,
Anoche, una vez.
una vez. Pero no por la operación, sino por la columna. La operación no tengo apenas una sensación y nada más.
You can see how they don't feel pain, and they manage the pain with oral, normal, common analgesics like acetaminophen, Thoracoscopic, and pregabalin. She was discharged from hospital at day 2. And this is our multimodal analgesic protocol for VATS lung resection. They're quite similar. Started with pregabalin 7 days before, and acetaminophen 1 gram oral, and then the patients during the surgery we prefer the opioid sparing anesthetic. We have our anesthesiologists. They don't want to use also opioids. So with the cryoanalgesia, they found that they use less opioids every anesthetic, every surgery. And as a post-operative, as we mentioned, the acetaminophen and also Thoracoscopic and pregabalin. So what we are doing, or what we want to do in the future, or one of our future directions is perform a Percutaneous Cryoanalgesia trial for non-surgical rib fractures. It's something we see a lot of elderly patients with rib fractures, and those patients you are not going to operate, and if they suffer pain, they need to receive a lot of opioids. So that's the same mechanism to unoperated patients, and this for elderly patients, I think it will be they will receive a good treatment and maybe will improve the results and with less opioid consumption. Also, this is we'll do a cryo arm and a control arm of both of them receiving analgesics if they need, but some of the cryo arm we perform percutaneous cryoanalgesia and plus blockade. We assess the secondary outcomes will be the days of return to work, normal activities, respiratory complications, quality of life, and patient satisfaction. Also, the appearance of neuropathic pain appearance. We will see. The idea is to perform a randomized control trial. It's not easy to perform, but maybe we will try to do it because we really believe that it's a good intervention for the patients. So the conclusions: intercostal cryoanalgesia offers prolonged block 4 to 8 weeks, no permanent damage to the nerve, an excellent opioid-sparing profile from patients with Pectus repair, and also we can find out some good results in rib fractures patients with less consumption of opioids during the discharge, and also the visual analgesic scale at day 30 and reduction of morphine consumption during the in-hospital stay. In pulmonary resections, also we really believe that the results will be better, and according to the publications the last year, that they found they are not useful and they are not our reality. We are seeing other things that the publication of the randomized controlled trial that they said that cryoanalgesia is not working. For us, it's working perfect, and we think that maybe it's an issue of technique, that how they apply the probe, and also we are the randomized controlled trials are with other company or machine, so maybe it's different way. Maybe this probe is designed for thoracoscopic, so it's the apply of a probe in the intercostal bundle. It's very applied. So, and that's why we have these results. We don't have that incidence of neuropathic pain. And percutaneous intercostal cryoanalgesia is effectively enhanced postoperative pain management in patients with undergoing surgical stabilization of refractures. Thoracoscopic cryoanalgesia has become the first choice for pain management in Pectus surgery. I don't operate anymore any patients, adults, without cryoanalgesia. I don't want complications. I don't want patients suffering. So more prospective randomized controlled trials needed. This always sounds at the end of every presentation. I think this is what we need. We need patients getting better of their pain, and so that's what we have to work for. And I need all the community, doctors, anesthetists, thoracic surgeons, interventionists. This is a place for we can enhance the recovery of our patients, and also it's something we have to work for. So this is my team, Mar del Plata, we work. Thank you so much for everyone, and this is my team in Clinical Pectus. Also, they do the best for me and always helping to do what I do. So thank you very much for here. Hoping you enjoy the presentation and could learn something about cryoanalgesia.
Matías, thank you so much for a wonderful presentation. And I can tell you that everyone loved it because I can see in the chat all the comments. And the thing is that you got so many questions. So let's see how many you can answer now. If you could please close your presentation, stop sharing the desktop, so then I'll be able to show the questions. Okay, so let's go from the first one.
You are going to read? Okay.
Do you combine cryo with original anesthesia?
Yeah, we always do spinal blockade, erector spinal blockade, and in refractors also when we puncture we're not doing the ultrasound-guided puncture. We instillate bupivacaine or ropivacaine, and so that's performed the first blockade. Because of percutaneous cryoanalgesia start working to 24 to 48 hours. So the first analgesia is because of the blockade. So the erector of the spina is we prefer the anesthetist, or we perform guided by ultrasound. It's an easy blockade to do it. And also the combination with cryoanalgesia, they are perfect because the first 24 hours, 48 to 48 hours, the patient is covered by the blockade, and next and then started the cryoanalgesia working. So you can see at the day 2, the patients are doing very well, and so that's why we combine.
Thank you. Patient awake or in sedation during percutaneous cryo?
Well, that's a good question. Now, because of the patient are going to be operated, they are under general anesthesia, so that's why we perform most of the procedures in general anesthesia. But the idea is now, when we're starting to treat patients with rib fractures, they're not going to be operated, and we want them to go house quickly. We are going to do a blockade in a place we can do procedures. It's not an OR. So the idea is to start doing with sedation or just with a blockade. But it's painful because you have to puncture with a 14 gauge catheter. So it's a huge one. So, but we can do it with sedation and also with local anesthesia.
Okay. Have you ever had any vascular injuries during the cryo procedure?
No, because it's not. When you are doing, if we can, you can see the video. It's control the function, and you go in the middle of the space. You don't go in the below the ribs. So it's if you find that you have blood when you are aspirate, you go back and punch in the middle of the space, and you it's not common to find the vessels, so we don't have that kind of complication. Sometimes maybe I find that I punch, so I go back and puncture again, and that's not a complication. It's not we never found that.
Okay. Matías, what do you think about the technique of freezing the intercostal nerve for 1 minute along with the collateral nerve for 1 minute? This approach has recently been promoted by some American doctors for thoracoscopic access.
Yes, I believe it's a good thing. We try to do that because if you don't control the collateral nerve, that maybe prolong the cryonalgesia time. But I think it's a good thing. And if you see the collateral nerve, we freeze them. But if not easy to see, because, for example, in Pectus repair, the access, you have the lung is collapsed, but the patient is in a position that is not, you cannot access to the spine. So you go as posterior as you can. But it's a good thing. I think that maybe if you can see the nerve, it's a good thing to freeze it. The idea to go posterior and to take more than one space when you freeze, it's that to control those collaterals. So, for example, I perform uniportal VATS, and I try to go one space below and one space down. So, up, and to control the possibility to control the collateral nerves. So I think it's a good thing. And if you see, but also you have to realize that if you want to control them, for example, Pectus repair, you have 5 minutes and 5 minutes more. So it will be 10 minutes per hemithorax. So it will be a long surgery or a longer cryo time.
Thank you. Any injury to pleura, lung injury during probe insertion time?
No, we don't find that problem, and it's possible to have it because you are functioning. But with the ultrasound, you can see perfect when you see the pleura and you instillate water. You see the pleura goes down. So it's I don't know, if you injure the pleura during the procedure, most of patients are going to be operated. So that's not, it wouldn't be a problem. If you're doing that thing for a patient who have chronic pain, which have a lot of patients with chronic pain, and if you have that problem, you have to put a chest tube. It's not a big deal, but we don't have patients with that complication because we manage very good the ultrasound, and you perform the function controlled by ultrasound. It's easy to avoid that injury.
Okay. Since at times the effect of cryonalgesia can be delayed by several hours, is it sometimes recommended to inject local anesthesia into the intercostal nerve prior to performing cryonalgesia in order to prevent this? Do you use this approach, or what are your thoughts on it?
Yeah, perfect. I think I answered that question with the blockade, and also it's a good thing. That's the main thing. That's why we use blockades associated with cryonalgesia, and also it's better with patients when we perform percutaneous. We don't know exactly, but we believe that because the probe is smaller than the thoracoscopic probe, and that's why the start of a cryonalgesia is a little bit later. When with the thoracoscopic probe, you find out that patients at day one, they are perfect, they don't feel pain, just pressure, and that's something you have to teach to the patients because they don't know. But the numbness and of impression it's what they have, but the combination, I think it will be perfect because patients don't feel pain. It's a painless surgery, so it's perfect for me. We have anesthetists that they like to do blockades and associate local anesthesia for the surgery, so they know that they don't use they use less opioids during the surgery. That's incredible for me.
Tramadol is no better than placebo for post-operative pain and also nausea. Gabapentin is also of no good for post-operative use. Anyhow, very good is cryo. Thank you. Any comments?
No, I think the protocol with tramadol is for patients with Pectus repair, and it's a protocol that we use it, but most of patients don't receive it just once, maybe at the first day, and we don't have problems. I also agree that it produces nausea, but like it's the same as morphine and all the opiates. That's a problem, which we want to avoid it. Gabapentin is also not good with that. We use pregabalin, and we don't have problems with pregabalin, and they are well tolerated for patients. And we believe that that's maybe one thing that for patients to get better toleration and not to avoid neuropathic pain post-operative associated with cryo.
Thank you. What are possible major complications of cryoanalgesia, if any?
Well, yeah, the complications are not so big complications, but the common are patients with neuropathic pain, but solved with the treatment. It's when always you treat a patient with a surgery. I have patients with neuropathic pain after a common surgery or thoracotomy or a VATS before I use cryoanalgesia. So every incision, every what you do to an intercostal nerve, it can generate neuropathic pain. So not always the cryo is the why you have neuropathic pain, the cause of pain. So that's a complication. And well, if you don't perform a correct technique, well, you can have what you think, what you want to have. So if you do a cryoanalgesia without the deflation of the lung, you can injure the lung because you're touching the lung. But if you do it with selective intubation, you don't have that problem. So it depends on the if you are safe with the technique and you do what I explained it to you, it's not so big complications. Maybe I think it's chronic pain is one of the common.
Yeah, thank you. What is the limit to intercostal levels you would freeze and why? I ask because I hear of abdominal wall, so the heariness forming. You had any issues?
Yeah. Well, the guides recommend not to go as below maybe more than 7 space. But now with the RATS surgery, we put the robot in those spaces. So we have to perform cryo over there. So the patients complain of that sensation in abdominal wall that they said they have something there. They feel like they have, I don't know, they don't refer pain. They say like numbness or something, and it's like that pseudo hernias. But that's recover. I made the patient went to the physiotherapist and perform exercises. And most of patients are elderly patients, not in young patients. But it's better no go below of the 7 space because you will affect those nerves, and no go as up more than 3rd space because if you touch the 2nd nerve, maybe you can have allodynia in the mammals. So for women, and also it's that common for them. So we try to go to from the 3rd to the 7th, no below that for Pectus. Now, well, in patients with thoracoscopic surgery, if you are doing VATS, you don't go more than 4th and 5th and 6th space. And now with robotics, we are going below that. So we found that problem, but it's temporary. So the patients recover of that problem. So it's not a big deal, but that's my recommendation. So if you want to try the pain in robotics, you go below that 7th space, and you have to advise the patient, say, okay, you will feel this, and no worries about that. We can do physio and we'll recovery. So, but yes, that's a good question. Thank you so much.
Is percutaneous sleeve for rib fracture? Do you have any tips to target the nerves, or just place the probe in the center of ICS?
Yes, just we study some. We found some papers about where the nerves goes, and most of the publications refer that the nerve goes in the middle in most patients. So just go to the middle. It's the best place to find most of patients' nerves, and to avoid the injury of the vessels. So the question is that. So go just in the middle.
Okay. Matías, I am pleased that you use 1-minute cryoanalgesia, and thank you for your recent publications. Similarly, 1-minute procedures are already being routinely used in Poland, USA, Spain for NAS cases. This provides significant savings in operating time while achieving the same pain reduction effect. What is your opinion on applying the same algorithm 1 minute for thoracotomy or VATS in thoracic surgical procedures, lobectomies? Thank you.
Yeah, I agree. I agree with you. I'm performing 1 minute when I do thoracoscopic. I'm still doing 2 minutes the percutaneously, because when we started with percutaneous, I think maybe we were the first, maybe in the world, because we started in 2021, and well, we say, okay, I started with 3 minutes, and we will see. So it was a long time doing cryoanalgesia. I say, let's try 2 minutes, and the patients do it good. And now we have our partner, Dr. Finger, in my hospital, who performs many blockades, and he do it in this way, 2 minutes, and he used the frost in the middle. So, but it's different to try chronic pain from postoperative pain. But yeah, I agree with you. Now I'm performing 1 minute in thoracotomies, VATS, and thoracic surgery. And maybe we will try to reduce also the percutaneous to find out which is the best time for, if it's 1 minute, it's better because it's less time. Thank you for the question.
In your opinion, is it necessary or possible to perform cryoanalgesia in uniportal procedures?
Yeah, I have many. I perform a lot of procedures. All my procedures, I perform cryo. All my surgeries. If it's rib fractures, I perform cryoanalgesia. If it's a lung resection, I perform cryoanalgesia. It depends on most of patients. For example, in cryo, in VATS, I perform percutaneous. Our series was about that. But in robotic, now I am performing every procedure with thoracoscopic, and they are working perfect, both of them. Just the delay of a percutaneous, just a couple of hours more delayed, but with good results.
Would it be possible to get the presentation afterwards for self-study? So that is a question.
Yeah, no worries. I will send it to Monica. Monica have it, so
yes, I've got it.
You can send it to him. Yes, no worries. It's an honor for me.
Send us an email. Thank you so much, Matías, for this, but there are more questions.
Okay, no worries.
How many levels of intercostal nerves are to be treated with cryo? How do you decide what is needed? Because if you miss one of them, you do not have sufficient analgesia?
A really good question. Well, in Pectus repair, we perform 5 levels, both hemithorax, from the 3rd space to the 7th space, as posterior as you can. The point, the target of the band, you will find the target is 3 centimeters from a sympathetic chain. And by VATS or robotic, you go from the anterior to posterior, and also you want to go as posterior as you can. And well, the number of levels, maybe when we started, we decided to say, okay, for example, for unipolar VATS, we said, okay, we have the 5th intercostal space where we perform the incision, and well, we're going to operate. So we obviously we will perform cryo over there, and then we go one upper and below the space. So just to catch up those collaterals, and that's what when we start, we decide that just to try if they are going, and they're really good. Okay, so we decide to continue with that, but it's I don't know, the scientific response to that, because I don't know exactly how many, but we found out that in those spaces for Pectus repair they're doing okay, and for thoracic surgery just go one upper and one below, and it works.
Okay. Have you observed any complications from having a motor block of intercostal nerves?
Well, that's the hernia. When you go more than below that 7th space, the pseudo hernia in abdominal wall, they refer like they have something there. They are not moving correctly, but it's temporarily. So we talk about that for the patients, and we said if those happens to me when I go below the 7th. So if you go below the 7th, you will find that problem, and you have to advise the patient that they are having that complication, but it's temporary. In 6 months they are healing and doing perfect. And but you can send them to physiotherapists and perform exercise, core exercise, and it's not a big problem.
Okay. How can we explain the cryo onset latency in your opinion?
Well, that's something we talk a lot with our team, and I think that's the size of a probe. It's one thing, because the percutaneous probe is smaller than the thoracoscopic probe, and that's the difference between both techniques. And the latency regarding the beginning of the when you started to feel the analgesia, because we saw that the patients, the first 24 hours, they don't have completely, because most of patients receive some extra opioid during that time in all our series, in refractors, in Pectus, and also in lung resections. So they have a latency, but I don't have I cannot answer that question. It's maybe biology, the time that it takes to all the cellular mechanisms to. I don't know exactly why the latency. It's when we found out that we learn a lot more, but I don't have an answer for that.
What are the risks related with percutaneous cryo?
Well, I mentioned that about the pneumothorax. Also, if you puncture the vessels, you can have a pneumothorax. Those are complications you have to mention to the patients, but I don't really have any of that because of it's controlled by ultrasound, the function. So use a 14 gauge angio catheter, so it's a huge needle, so you have to be careful with that. But if you do the correct way of applying the ultrasound probe, and you can read our publication in Short Communication on how to do it, and it's safe. But those are the risk, and you can do it. If you don't do the correct way, the function, you can have those problems. And it's the other way. The other complications are related. That's the same as other cryoanalgesia techniques, no different. Just these are the differences because you have to punch.
Okay. So what still do we have? This one. Is your 1-minute protocol for the percutaneous or the thoracoscopic approach? Sorry.
Yeah, I answer also that. It's just 1 minute for the thoracoscopic. For the percutaneous, we started with 3 minutes, and now we are performing 2 minutes, and that's working good. It's not so much because we have rib fractures. There's many. You have to cryoablate all the spaces rib fracture, and so 2 minutes each space. And well, it's a long time, but well, it's better for the patients. You can see the videos and how they recover. And when you started doing, you won't do any surgeries without cryoanalgesia. I know you'll find out that it's a great. You'll have great results with it.
How close are you happy to cryo near the spine?
When you are doing thoracoscopically, you are 3 centimeters lateral to the spine, and when you are doing cryoanalgesia percutaneous, you go lateral to the erector of the spinal muscle, so you can see better the pleura, and you don't need to punch through the muscle. It's more painful, and it's not you don't have good ultrasound window. So when you are going percutaneously, look maybe 5 centimeters. You'll find the best window to get function, and you try to go as possible as posterior, avoiding the muscle. I don't know if I answered correctly, but it's the idea that we don't have a measure to do that, but go lateral to the muscle, and you can perfect puncture the bundle.
Beautiful, thank you. Do you get post-cryoneuritis? How do you manage it?
Yeah, we have not so big amount of patients, but we manage with continuing the therapy with pregabalin every 8 hours, and as the patient's needs, and when the pain is getting better, we go decreasing the dose of pregabalin gradually and until the pain disappear. But yes, it's not as common as it's reported in the randomized controlled series or other groups. But if we have patients with the pain, we treat with pregabalin. And as I mentioned to Monica, the neuropathic pain, you can have neuropathic pain after a trauma or after an incision or a rib fracture. So not the cause of pain always. If you operate a patient, it's always the cryoanalgesia. But well, we need to study more that how to treat and how to prevent. But the way we prevent is pre-medicating patients and applying correctly the probe in the middle of the bundle. So that's how we prevent.
Thank you. The next one is, do you perform the percutaneous procedure with the patient already in the operating room or the day before the surgery?
Well, we try to do that, but our health system, it's quite complicated here, because if you need to do that, you have to go get the patient into the hospital, generate cost, a lot of cost, and so maybe it's not for the system. It's not good there because it's too. I don't know how to say it exactly, but we perform the same day. We try to do it separated 4 days, and it wasn't a big problem if we do it the same day. Maybe the patients do better the first day, and the second day both are okay. So just for me, maybe because of to get the patient 2 times to the hospital, we just do it the same day. But yes, it's the group from Valdebrón. They perform percutaneous cryoanalgesia 4 days before the surgery, and they have perfect results.
Great. Can you describe access for percutaneous rib fractures?
Yeah, it's easy to perform it, and for the access, you go posterior of the fracture, and the same as you are doing a cryoablation for percutaneous for a surgery, as you go posterior, and you find in the intercostal space parallel the ultrasound, and you punch the bundle in the intercostal space, and then you see the pleura, and you instillate bupivacaine or ropivacaine to epidural dissection, and then you get inside the probe to the catheter, and then you freeze the nerve, and it's the same. Every rib fracture space, you perform cryoanalgesia. If you could do it upper and below the last rib fracture, it's better. If you cannot, because if the second space, or I don't know, maybe if too low, but we always do cryoablate every single space that is fractured.
Okay, the next one is, what are your opinions regarding patients who experience neuropathic pain after cryoanalgesia? What could be the cause? Poor cryo technique, medication coincidence? Could the use of opioids before surgery be a reason for neuropathy after cryo?
Well, if we, I read the 3 evidence of Wexler. They have 2 randomized controlled trials, and one they compare patients with VATS or RATS, and with cryo and without cryo, and they assess the neuropathic pain and the consumption of opioids. And I don't know. In one of the publications, they publish a lot of neuropathic pain, and they use the Lance scale, and they establish that the patients with numbness have 3 points, and it's obvious that a patient with cryoanalgesia will have numbness of the chest. So if you put to the patients who receive cryo 3 points more than the patient without, they don't receive cryo, they don't have numbness, it's obviously that you will enhance that score that they use. And well, the other one, they compare VATS and robotics. I think that maybe it could be an issue regarding the technique, how they apply as I show you, how they apply the probe in the intercostal space, and maybe, well, we use different machines, so probes, so maybe we don't find that our patients have those scales of neuropathic pains as they describe, or the appearance of patients, the number of patients that they mention in their paper. So I think that it's a matter of continuing to investigating how this happened and how can we prevent it also. But because the patients have better recovery, have less pain, they don't use opioids. That's all of us agree about that. But well, this randomized controlled trials, that there's the best evidence in the literature. There are 2 or 3 papers that they don't find out our results, but I can mention many, a couple of papers that we have good results and not that amount of patients with with neuropathic pain.
And 3 more to go for you. So do you ever use redo cryo if redo NAS is necessary? And if so, what is the minimum distance of time between?
Yes, the answer is yes. We redo cryo. For example, not just for redo NAS, for patients with, for example, chronic pain, and we perform cryo, and then the percutaneous, no? And then the patient at the 6 months say, okay, I start again with a little pain, and we can do it again, percutaneous. And for example, for redo NAS, percutaneous is a great option because the patient is operated, and maybe patients with additions of pleura or patients operated with cardiothoracic surgeries, percutaneous is an excellent alternative, and you can perform it. And that's the versatility of this, the cryo painless, because you have in the same machine both alternatives, percutaneous or thoracoscopically, and it's great for that, because you have patient, for example, you perform a NAS, and that patient, and you need to, because you have bar displacement or something, and you have to do the NAS, and or you say, oh, this patient will have additions, and it wouldn't be easy to perform thoracoscopically. You can do it percutaneous, and that's a great alternative, and you can solve the problem, and the patient receive the best treatment. So the answer is yes. And sorry, they ask about how much time need to do it. No worries about the time. We perform percutaneous sessions every 2 months. If a patient have pain, then you can do it. It's not a problem.
Great, thank you. Does the removal of nurse bars cross sandwich require prophylactic analgesia percutaneous?
No. Just with the removal of the bars, the patients release the pain of having that bars inside. So with the blockade goes great, and the other day the patients are okay. It's not necessary to perform.
Thank you. And the last question: how long do you use pregabalin after surgery? Do you use it before as well?
Yes, we use before and after the surgery. If the patient doesn't complain of neuropathic pain, we use 1 week every 8 hours, and then we decrease gradually 1 dose for a week. For example, first week after surgery every 8 hours, the second week every 12 hours, and the last week just once a day, and then quit.
Okay, I think we do not have any more questions. The chat is full of different comments, but I'll take them from the chat and we'll send you. So if anyone from the audience would like to have the answers or more information, please let us know, send us an email. So Matías, that was an extremely beautiful presentation, full of knowledge.
Thanks so much
for sharing.
No, thanks so much for you to the invitation. It's an honor for me. I don't think that I'm enough prepared for this, but I'm trying to do it better each day. I'm trying to with my team in Clínica Pectus and Hospital Privado Comunidad, continuing to investigate and get what we start in this to get better and better results for our patients. So that's what we want. That's why we're here, to release pain of the patients and best recovery. I have a dream that sometimes the HERAS protocol will talk to us and say, okay, we are going to start with in thoracic surgery with cryoanalgesia. I hope that's my dream. And also,
we would love it as well.
Yeah, I hope that.
So once again, thank you so much, because I know that your calendar is extremely full and you are going.
Yeah, I have my flight in half an hour. Well, okay.
Once again,
they will pick me up.
Pleasure, an honor, and definitely we will repeat it. Thank you.
Well, thanks so much, Monica, for everything. Bye. Bye, everyone. Thank you for the attendance.